Welcome to UMDF's Ask the Mito Doc monthly webcast. Today, Dr. Amel Kara from Massachusetts General Hospital will provide an overview of mitochondrial encephalomyopathy with lactic acidosis and stroke-like episodes, MELAS, and help us to better understand what treatments and therapies are currently available. We will also hear key takeaways from the recent MELAS externally led patient-focused drug development meeting and plans for upcoming sessions at UMDF MitoMed 2026. Our moderator today is our very own Margaret Moore. Our Ask the Mito Doc webcasts are made possible through the generosity of sponsors, so we ask that you join us in thanking UCB. Mark your calendars now for UMDF Mitochondrial Medicine 2026, set to take place in sunny Orlando, Florida, June 17th through the 20th. Planning is underway to bring cutting-edge information, networking opportunities, and much more to the mitochondrial medicine community. We hope you will make plans to join us. The UMDF and the mitochondrial disease community have been celebrating the first FDA-approved therapies for mitochondrial diseases, and we will continue to work diligently to prepare our community for next steps with Vorzinity and Kygevvi, as well as advocating for more therapies and approvals in 2026 and beyond. For more information, check out the Medications tab on the umdf.org home screen. The path to drug approval can be winding and very, very long. For years, UMDF, along with many of our friends from similar organizations, have hosted listening sessions, as well as externally led patient-focused drug development meetings with the FDA. The Voice of the Patient reports, summaries, and advocacy events in DC have been extremely helpful in moving drug approvals forward. Together, we will continue to make progress. To read past meeting reports, visit umdf.org/umdfvop today. We would also like to remind everyone about our patient-populated registry. This is the ideal place to help capture the patient experience and overall journey to help us move toward cures and treatments for mitochondrial disease. Information about the biorepository can also be found at umdf.org/mitoshare-registry. Please check it out today. Please note, the information provided in this webcast is for general information only and should not be relied upon as a substitute for professional consultation with a qualified healthcare provider familiar with your individual medical needs. Please consult your primary physician and/or specialist before changing the course of your care.
Welcome, everyone. I'm glad to have you here for our monthly Ask the Mito Doc webcast for February. Today, we're going to be talking about understanding MELAS, current treatments and therapies. I'd love to introduce Dr. Amel Kara from Mass General. She's going to be our speaker today. So come on off camera, Dr. Kara. And wanted to talk a little bit about why we're hosting this today. There's been a lot of activity in the MELAS space. Clinical research, clinical trials, recent February 10th patient-focused drug development meeting, and we thought it was a good time for an update. I did want to, in referencing the Voice of the Patient activity at the patient-focused drug development meeting, I wanted to focus on that a little bit. I think you saw the slide earlier that showed the different regulatory Voice of the Patient meetings that we've held in the past and why they're so important and just what this means to our community. This is a way for us to really communicate to the medical community, the community at large, what our patient families deal with. So for all of you that have participated in those in the past, we are so grateful. It really makes a difference and your voices matter. I'm going to stop talking. I'm going to invite Dr. Kara back on and let her get her presentation started.
Thank you so much, Margaret, and thank you for the UMDF for having me. I am going to share my slides and we can start. So as you heard, my name is Amel Kara. I'm a geneticist and an internist by training, and I do follow mitochondrial disease patients at Mass General Hospital in Boston. And today I want to walk you through what MELAS is, why it happens, what it means for patients and families, and where treatment and research stand right now. So my goal is to make this understandable and practical for you. And hopefully we have time at the end to answer some questions. These are my disclosures and disclaimers. I work closely with many mitochondrial organizations and research groups. I also participate in research studies and trial and advisory boards. I share this with you to let you know that I am involved in both patient care and clinical research, and everything I will discuss today is based on current scientific evidence and ongoing work in the field. And so what you're going to hear from me today is a little bit about the gene that causes MELAS, what MELAS is, what the management of MELAS is, and the exciting news about therapies in development. Okay, so let's start off by talking about MELAS, which fits into the broader category of primary mitochondrial diseases, or PMD. Primary mitochondrial diseases happen because there is a change in the genes that affect how mitochondria work. And so mitochondria are the energy factories of the cell. Every organ that we have depends on energy and on mitochondria to function properly from the moment we open our eyes throughout the night. Everything we do, life requires mitochondria and energy. And so some mitochondrial diseases are caused by genes in the nucleus, and I'm going to use the pointer here. So genes in the nucleus within the chromosomes, these are inherited from both parents, mom and dad. And other mitochondrial diseases are caused by mitochondrial DNA problems, which are unique to the mitochondria and inherited from mothers and passed on to all of their children. So MELAS is a mitochondrial DNA disorder where the mitochondrial DNA becomes affected. It's not a nuclear DNA disorder. And PMDs in general are more common than most people realize. Many people carry mitochondrial DNA changes, but fewer people develop symptoms. And a smaller group of those people who develop symptoms will develop significant symptoms. And an even smaller number of those will go on and develop MELAS specifically. So to give you an example, there are about 30 to 40 million people worldwide who carry a mitochondrial DNA variant. These are carriers of the change in the gene, but only about 1 to 2 million of those will manifest with symptoms and manifest with disease. And that disease can affect one organ or multiple organs. And amongst those, 300 to 400,000 will manifest this 3243A to G mutation. So M stands for mitochondrial DNA. 3243 is the position where the letter A is changed by a letter G, and that in itself, even though it looks very small, can cause a lot of health problem. And so this explains why the disease can look very different from one person to another. And this variability can be confusing and sometimes frustrating, but it reflects how complex mitochondrial biology is. So most MELAS cases are caused by this 3243 mutation or change. There are other mitochondrial DNA mutation that can cause MELAS, but the most common one is this 3243. So a lot of the time, during this presentation, we'll focus on the 3243 as a representative of all MELAS changes. And so what happens on the cell level because of this change in the DNA? So when mitochondria do not function properly, energy production drops. And mitochondria will not function properly because this little letter change in the mitochondrial DNA code is going to affect how the mitochondria makes energy. So energy production drops, cells produce more stress signals, inflammation can happen, damage to the mitochondria can happen, and they may become inefficient at clearing the damage that is caused by the mitochondria. So over time, this leads to symptoms in high energy organs like the brain and the muscle. So the organs that require most energy are the ones that are going to start suffering first and will have the most severe effect. And the brain, which uses 20% of all of our energy every day, is the part of the body that suffers the most when you have MELAS. So in these next two slides, what I wanted to show you is that aside from the fact that we know that the DNA changes, and one of the most common changes can cause MELAS. What I wanted to show here is that in MitoShare, where we have thousands of patients, MELAS represents 13.7% of all the self-reported diagnoses that patients have. So that comes third after mitochondrial myopathy and mitochondrial disease that cause multi-system involvement. So it's pretty common in terms of the broader mitochondrial disease group. And even when we look at the clinician registries, these are registries where physicians input their patient information. This is the North American Mitochondrial Disease Consortium, led by Dr. Mito out of Colombia and funded by the National Institute of Health, and has been ongoing since 2011. Again, you see that MELAS represents the third largest group of patients that that are found and that are being treated in our clinics across the US and some sites in Canada. And so what does MELAS really stand for? Because we keep saying MELAS. It's an acronym. It stands for mitochondrial encephalomyopathy, lactic acidosis, and stroke-like episodes. So encephalo means affects the brain, and myopathy, it means affects the muscle. And lactic acid is something that it's a byproduct of the mitochondria not functioning properly that we can measure in the blood. And stroke-like episodes affect the brain, and I'm going to talk more about those. However, what is very important to say today, and it's a message that I want to leave you with, is that not all patients experience all components when they first start having MELAS symptoms. So they don't always present with all of these issues at hand. And by the time we see them for strokes or stroke-like episodes, they already have severe manifestation of the disease. And so this often leads to delayed diagnosis and misclassification, because when patients start having just muscle problems or just seizures or other symptoms, doctors and other providers may not put one and one together and think broadly about what can be causing all of these symptoms at once. And so the other message that I want to leave you with is that the 3243 change doesn't mean automatically that a person has MELAS. So this is very important, because MELAS is a clinical diagnosis that applies only to a subset of carriers that have the 3243 mutation or other mitochondrial DNA mutation. And about 10% of patients who carry this mutation will go on and develop MELAS. And so the majority of people with this DNA change won't develop MELAS ever. They can develop other problems, other health problems, but MELAS specifically, only about 10% of patients will develop that. And so when we talk about MELAS, we're specifically talking about patients who have this clinical presentation of the disease. And that is very important to understand, because unfortunately, when patients get the genetic testing, for the non-expert, and sometimes even the expert, I have to say, we used to interchangeably use the 3243 mutation as an equivalent to MELAS. And that causes a lot of anxiety for patients and their families, because they go home and they Google it and they find that, oh my God, I'm going to have all of these problems and all these strokes, where in fact, 90% of all people carrying this change are not going to develop any of this. And so we have to be very careful how we label patients, so not to cause more anxiety and more worry and more emotional burden when they get these diagnoses. And that's also the reason why over the years, the MELAS definition continued to change. So the MELAS was first described in 1984. And this definition came because doctors were observing in their clinic patients who were coming in having all these symptoms. So it was a clinical diagnosis initially. And then as technology evolved, they added a layer of, okay, we did a muscle biopsy and this is what we saw in the muscle biopsy. So this is now part of MELAS as well. And then we developed blood test and urine test. And then we said, oh, okay, look at all these features. They are part of MELAS. And so over the years, we've changed so many times how we define MELAS that it also became very complicated for the non-expert to really differentiate between what we should be calling MELAS and what should not be called MELAS. And so this culminated in November 2025, where an international group of mitochondrial disease experts met in Italy in Pisa, and they sat together for many days and they came up with a new standardized definition of MELAS. This has been submitted for scientific publication and will hopefully be out soon, but this is the new definition of MELAS. MELAS is a primary mitochondrial syndrome caused by a pathogenic mitochondrial DNA variant characterized by one or more stroke-like episodes with associated epileptic and/or encephalopathic features in the context of either genetic or biochemical or muscle histological evidence of oxidative phosphorylation dysfunction. So what is a mitochondrial oxidative phosphorylation? It's the process by which cells use oxygen to turn food you eat into the energy that powers our body. Okay, so this is now a new definition of MELAS that is more clear, and it is emphasizing that you need to have a mitochondrial DNA change to be able, and the symptoms that go along with it, to have a diagnosis of MELAS. And more specifically, you need to have a mitochondrial stroke-like episode, which is defined as an acute or subacute evolving brain syndrome that can manifest at any age, which is important, with neurological and/or psychiatric symptoms typically occurring in association with cortical or subcortical MRI changes with or without EEG abnormalities. I know this is a mouthful, but the idea is that we eliminated the age limit that before stated that patient with MELAS develop symptom before and strokes before the age of 40. Now we agree that you can develop MELAS at any age. It has to have these stroke-like episodes that cannot just be how you feel, but we need to be able to see changes on your brain MRI to be able to call these really stroke-like episodes. And you can have also abnormalities on the EEG, which measures the brain waves, but that's not absolutely necessary for this diagnosis. Okay, so what makes MELAS confusing? It's one of the most confusing aspects of MELAS, which is its variability. Each person has a mixture of healthy, which is depicted here in blue, mitochondria, and mutated mitochondrial DNA, which is represented here in red. So that mixture is called heteroplasmy. Heteroplasmy is how many mitochondrial DNA copies are changed in your cells. And the proportion of abnormal mitochondria varies between tissue and across individuals. And so in the same individual, if you looked at every organ they have and every tissue, you may find very different heteroplasmy levels. And these can be very low heteroplasmies to medium high to very high heteroplasmy level. And these heteroplasmy levels can also vary across people. So this is why one person may have more muscle symptoms and another may have more brain problems and another may have hearing loss or diabetes, but no muscle or brain issues. There's no single pattern that we can make out. Every patient is really different. And even within the same family carrying the same exact mitochondrial DNA change, we can have very variable presentations of their disease. The one other thing that we have to understand is this threshold effect here. If critical tissue, like the brain, cross an energy failure threshold early in life, then symptoms may appear in childhood. Whereas if that threshold is reached later in life, then patient may develop their symptoms in adolescence or adulthood. That's why we have some patients who develop symptoms early and others late. And this helps explain why MELAS looks so different from one person to another. So MELAS does not just affect one organ, as I said, because energy is required everywhere in our body. Multiple organs are affected, and it can present in every cell of the body and can affect any system in the body. This variability is also making MELAS hard to diagnose early, and why treatment plans must be individualized to every patient. It also explains why comparing patients to one another is often not helpful, because each case follows its own path. And at present, unfortunately, we don't have any validated tools that can reliably predict disease severity or the timing of the symptoms onset or the expected trajectory that each patient is going to have and the progression in any individual patient. We'd like to do that, and a lot of people are working to try to figure out how to do that. But just looking at the heteroplasmy level in different tissue is not going to be that much helpful because of all the variability we observe within the same body, within the same person, and within different people. So what we can say is that the brain and the nervous system and the muscles are highly affected by this disease. So these are the two major systems that get affected. And if you look at this list here, anything can happen in the brain and in the muscle. You can have hearing loss, vision problems, seizures, migraines, strokes, balance issues, neuropathies. And if you really look at the manifestation, more than 25% of patients with 3243 will develop these brain-related and muscle-related issues. And then the interesting thing is that this is a study that was done by an Italian group where they looked at their 3243 patients at the onset of their disease or at the diagnosis, and then they looked at them at the last evaluation, which was about 10 years after they first presented. And what we see here is that most patients, when they get diagnosed, they already have hearing loss. They have seizures, they have diabetes, they have muscle issues, they may have migraine, stroke-like episodes, muscle weakness, exercise intolerance. And then what happens over time is that the proportion of these patients that have these symptoms increases, and then they start developing more and more symptoms everywhere else in the body. So this is a disease that progresses, and it may start with the brain and the muscle, but it can evolve to affect everything else. And MELAS can affect any race and can affect both genders and can present at any age, as I said. And the first stroke-like episode usually occurs around age 14 to 15. It's a progressive disorder with a high burden. It affects patients in two main ways, chronically and acutely. And so if you think about chronically, like day to day, when you ask patients what they suffer from, in general, our primary mitochondrial disease patient complain of all of these things at once. This is an elegant study that was done by my colleague, Dr. Zolkipli Cunningham at CHOP, where they asked hundreds of patients what their most bothersome symptoms were. And you see here, the larger the word, the more reported the symptom is. Fatigue, exercise intolerance, weakness, gastrointestinal problems are really prominent. And those are the symptoms that our MELAS patients also suffer from. And at any given time, a mitochondrial disease patient can have up to 16 different symptoms on any given day. And so it's a very burdensome disease that day to day will affect multiple organ systems and can cause a lot of disability. But also, MELAS can cause an acute problem. On top of all of the things that are experienced by patients every day, you can have an acute burden with these stroke-like episodes. These stroke-like episodes can be seizures, sudden neurological decline. They can occur at any age and can cause permanent changes sometimes. What you see here are MRI images showing these stroke-like lesion here in white. This is not supposed to be white. Here you see a more extensive one. Here you see a lactate peak. And here you see an EEG with some seizures and severe migraines in a patient. So despite the name, the stroke-like episodes are not typical strokes caused by blocked blood vessels. Instead, they occur when the brain cells suddenly cannot produce enough energy to function. And they can be triggered by stressors like infection or a fever, dehydration, surgery, or even an emotional drain. And while having stroke-like episodes, patient may also exhibit seizures. So stroke-like episodes manifest differently in different patients, and all these symptoms can be seen: seizures, confusion, vision loss, weakness of certain parts of the body, speech difficulties, changes in behavior, often evolving over hours to days. So MELAS can be chronically disabling, but on top of that chronicity, there are these acute events that can also happen. And so clinically, MELAS follows the stepwise deterioration rather than a gradual decline. Importantly, these stroke-like episodes are not isolated events, but tend to reoccur unpredictably over time. And so that's what really causes the more disability, this cumulative disability and loss of independence over time, because each episode results in additional brain injury. And although partial recovery may occur, damage accumulates over time. With more SLEs you're having, the more brain damage you will have, leading to progressive neurological disability and increased vulnerability to subsequent episodes. At some point, though, the brain will burn out. There's no more tissue to damage, and so patient become very disabled. So overall, it's progressive, unpredictable, unrelenting, and deteriorates with stress. And that's why it's important to manage stress adequately. And then when you look at the overall effect of this, mitochondrial diseases in general are highly variable, but symptom onset and surviving, ranging from infancy to late adulthood, can have a heightened mortality compared to the general population, as you see here. These are the Mito patient, these are normal people. So Mito patient can have problems, can pass away earlier in life. And then if you look at MELAS more specifically, studies have shown that MELAS can shorten lifespan as well, but the risk varies widely depending on the severity of the disease, the organs that are involved, and the frequency of these stroke-like episodes. So how do we diagnose patients with MELAS? Well, today, diagnosis of mitochondrial disease, MELAS included, is genetics driven. Genetic testing is the most important step. It allows us to confirm the diagnosis and guide family counseling. It also allows us to have a better sense of what to expect when we have identified a specific gene like the 3243, for example, for MELAS. There are many genetic tests that we can do now. The only rate limiting step is whether insurance will cover it or not. We are able to fully look at the mitochondrial DNA letter by letter. The nuclear DNA is a bit more tricky, but we're making progress there. And then once we have a diagnosis, we look at corroborating tests to assess how the mitochondria functions. These are your biochemistry tests. You might have heard about lactate and pyruvate, CPK to look at the muscle breakdown, GDF15 and FGF21. These are new biomarkers that we are using. The muscle biopsy, which was the tissue pathology that was relied upon many years ago, is no longer being pursued. So we don't need muscle biopsies nowadays. There are only very few scenarios where a muscle biopsy can be helpful. Overall, genetic testing takes precedence for the diagnosis, so we don't need a muscle biopsy any longer. But the most important thing is, because MELAS can affect any organ, we really need to make sure that even if the patient is not complaining about a symptom in a specific organ, that we can check that organ to make sure that there are not subtle changes that have not risen yet to the threshold where the patient is starting to exhibit symptoms before they do, so we can intervene and manage them and prevent them from further progressing. So we check the brain, we check the heart, we check the eyes, we check the hearing, we check everything, the endocrine system, look for diabetes, all of these things we need to do on a yearly basis. And so what do we do once we have a diagnosis? How do we manage the patient? So current treatment options revolve around the fact that MELAS is an energy problem. Your mitochondria is not working. It's not making enough energy. So what we need to do is really try to conserve the energy our body is able to make and try to make more as much as we can. So how do we minimize energy losses? Avoiding stressors, adequate rest with good sleep, nutrition, and exercise. Those are the main points that we go over with our patients. Again, there are currently no FDA-approved disease-modifying therapies, but we are working on that, and I'm going to tell you more about that. So, treatment. Oops, sorry. This is not supposed to look like this. Treatment for MELAS includes the acute and the chronic treatment. Again, remember, there are chronic problems and there are these acute problems. So for the acute problems, these are mostly the stroke-like episodes. We in the US, we tend to treat our patient with stroke-like episodes by giving them intravenous L-arginine. And that came about because a group in Japan many years ago, have used L-arginine, and they published that they see a more rapid improvement in the symptoms with L-arginine, and if they gave L-arginine chronically as well, they were able to prevent maybe some of these SLEs to happen. And so in the US, we adopted the IV use of L-arginine. But the problem is the treatment of these SLEs with arginine does not slow down the progression of the disease or revert the cognitive issues that the patient might have. And so we continue to do it because we don't have another option. But I can tell you that in Europe and in other parts of the world, they don't at all use IV arginine. And in fact, in this last meeting we had in November, it was clearly stated that we still don't have enough information to understand whether L-arginine or L-citrulline or taurine are really helpful, whether in IV form or oral form, because there have never been a robust clinical trial looking at their effect in a population that is of MELAS patients who are receiving them versus another population of patients who are not receiving them. And so these remain what we call empirical treatment. We give them because we have high hopes that they work. Biologically, it makes sense. Arginine improves blood flow to the brain, and when you're having a stroke-like episode, having more oxygen in your brain can be helpful, but we don't have robust scientific information to really corroborate that assumption. And so the other thing to note that all of these studies that were done out of Japan, they really focused on the 3243 mutation. So technically, only the 3243 patient, when they present with a stroke-like episode, should be getting L-arginine, and not all mitochondrial disease patients who present with a stroke-like episode should be getting them. And then other specific acute management includes hospitalizing the patient if they are having an infection or some new stressor that is putting a lot of strain on their body. Using anti-epileptic agent if they are having a seizure that can't break with the treatment that they usually get at home, or giving them intravenous steroids if they are having new brain lesion, which is something that we started doing when we have patients with a stroke-like episode, because some of these stroke-like episodes increase inflammation in the brain. And so when we give steroids, that can lower down the inflammation and help them recover faster. And then if they have severe acidosis in the body, we need to manage that acutely. And then really supporting the body with adequate nutrition and inpatient rehabilitation, because again, energy comes from the food that we eat. And most often when our patient end up in hospitals where there is no mitochondrial medicine expertise, nutrition gets forgotten. Patients get put on just salt water and they are not getting enough calories, where really giving the patient enough calorie is really, really important in these acute situations. Um, so then for the chronic treatment, what we do is we look at symptomatic care. Can we stabilize the symptoms that we have at hand? We do organ-specific management. Obviously, if you have a heart disease, you will need a cardiologist to treat your heart as if it was caused by any other condition aside from mitochondrial disease. We use the same drugs, we use the same management. And if you have kidney disease, you need a nephrologist. We treat your kidney disease regardless of whether the problem is caused by the mitochondria or not. And then we emphasize exercise and nutrition, because exercise is really helpful to try to maintain healthy mitochondria in the body, even though patients are fatigued, even though patients are weak and they have muscle problems. The more exercise you do, the better the outcomes are. And then really healthy eating to try to support the energy making process in the body. And then again, the dietary supplements, what we used to call the Mito cocktail, which is now much more restricted because again, we're lacking that that scientific evidence that this truly works. And we do, some doctors do recommend for their patient to be on L-arginine and L-citrulline and taurine. Again, we don't have any robust data to support any of these. And even if you take supplements, they haven't really demonstrated consistent, reproducible, or disease-modifying benefit, even though some patient, when you ask them, they do feel that they have more energy by taking them. Okay, supportive care is also very important, preventing complication from occurring and then supporting the patient as a whole with early intervention in children to support their developmental problems, social worker, case manager, support group, because this is not a disease that just affects the one person within the family. This is a mitochondrial DNA inherited disease. And so many members of the family might be affected, including the mother, who's often the primary caregiver for her children. And so if you have two children who are affected and a mother who is affected, the whole family is going through the process with like tremendous burden socially, emotionally, financially on the whole family. So anything we can do to support the care of the individual and the family is very important to do. Okay, so now I'm gonna switch gear a little bit to talk about new therapies. And what I want to start with is to tell you that across registries and multiple studies that were done internationally, two symptoms have emerged from our primary mitochondrial disease patient and MELAS as being the most bothersome problems. Fatigue and muscle weakness are very disabling for our mito patient. And when you ask patients, if we had a drug today, what are the symptoms that you would like treated? Or what are the symptoms that are most meaningful to you for us to fix? They mention muscle weakness and the chronic fatigue. And fatigue is one of the most common and disabling symptoms in the mitochondrial disease community. It's not ordinary tiredness because you worked out or because you didn't sleep. It affects physical strength, it affects mental focus, it affects daily functioning. Patient consistently rank it as a top priority for treatment development. And so fatigue in mitochondrial disease affects all sorts of things. It affects the mobility, employment, independence, and social participation and interaction. It has a huge burden and a huge impact on a day-to-day life. And so when we ask MELAS patients more specifically, aside from the fatigue, what has emerged is this cognitive related problem. So MELAS patients specifically report having and what is meaningful to them is really to improve their cognitive symptoms. So memory problems, difficulty concentrating, difficulty finding words, expressing speech or brain fog, difficulty comprehending speech. All of these have been repeatedly reported by MELAS patients as being problematic and wanting to have treatment for. So many trials have been conducted so far in mitochondrial diseases in general over the last 12 years, but only recently did researchers started targeting several specific pathways aiming at treating specific genes or subgroup of genes within the primary mitochondrial disease big umbrella group. So they have companies have used several ways of doing that by trying to improve energy production or reducing oxidative stress or supporting mitochondrial repair. And what we are going to review today is a few of these programs that are relevant to MELAS specifically. One such program is run by Tisento Therapeutics with a drug called zigosiquat. Zigosiquat supports blood flow in the brain and is hypothesized to rebalance the dysregulation on the cellular level that causes MELAS. So by improving mitochondrial energy production and neuronal signaling in the brain and improving cerebral blood flow, the drug aims really to improve the fatigue and the cognitive function and the exercise capacity of patients with MELAS. So this represents really a growing shift towards treating the symptoms that matters the most to patient, as I showed you, fatigue and cognition. And so what Tisento did is they started running the PRISM trial, which is a phase 2b randomized double-blind placebo-controlled crossover study, which where patients initially take the drug and then they don't take anything and then they take the placebo or vice versa. And this was open to adults with mitochondrial DNA mutation that cause MELAS specifically. And what was assessed during the trial was the fatigue and the cognition using different measures. This trial is now fully enrolled, and patients are transitioning to what we call an open label extension, where regardless of where what they got at what point of the trial, they will be transitioning to the real drug, and they'll stay in the open label extension until we know more about how this drug really affects them. The readout of this trial, meaning the results of this trial, are expected at the end of 2026. So lots of excitement to have been able to do this trial and for results to be forthcoming soon. Napazimone or KL1333 is also another drug that was designed to improve how cells handle energy and oxidative stress. This is a trial that was run by former Abliva, now Pharming. And the major clinical trial included adults with mitochondrial DNA mutation, which include the 3243, and measured fatigue and muscle function. It's also a placebo-controlled trial that is going to run for 48 weeks. This trial is ongoing in the US and in Europe. If you are interested and if you have a mitochondrial DNA mutation, you might be eligible to enroll. And so I will tell you later how to find these trials. And you're welcome to apply to be considered to be part of these trials. The Falcon study, which is this trial, has a companion natural history study called the MERLIN study. This is a study that is being run out of MitoShare, the UMDF patient registry. And this is a study where we're doing the exact same things that the patient in the Falcon study are doing, but from the comfort of their home. Patients in the MERLIN study are not getting the drug or the placebo, but they are still telling us all about their fatigue and their muscle weakness every 3 months. They do the same assessments as the patient in the trial are doing. And what we're trying to achieve is after 2 years, we're trying to compare the differences or the similarities between those patients who are at home and how their fatigue and muscle weakness evolves without any specific intervention versus those who are in the trial getting the drug or the placebo. This is data that the FDA is looking for, and this is data that is very important to have so we can better understand how these symptoms evolve over time with and without intervention. The third program that I'm going to talk to you about is for a drug called sonlocriminol. It's another investigational drug, and it works through 3 different mechanisms. It reduces inflammation, reduces oxidative damage, and restores the cell energy balance. It crosses the blood-brain barrier, so it goes where we need it to go in the brain. And this trial, the Kennerfin trial, is going to be an international study in Europe and in the US. It's a phase 3 randomized double-blind placebo-controlled trial as well, and is going to also focus on physical fatigue. And this trial is just starting in the US. There are 2 sites that have been activated already in London and in Nijmegen, and the US sites are forthcoming. And so how do you find these studies? Clinicaltrials.gov, you can type in mitochondrial disease. You can find them on the UMDF website as well. They have a clinical trial finder. And you can also reach out to your doctors and ask them to be part of any of the 2 studies that are now available, the Falcon study and the Kennerfin study from Condrian and Farming. Okay, so what's exciting, in the next 5 minutes, we are going to talk about new emerging approaches to treat MELAS and mitochondrial diseases in general. So up to now, we've talked about treatments that try to improve how mitochondria functions, treatment that use pills that you take orally to treat the disease symptoms and try to slow down the progression. And maybe if we are doing really great, try to reverse the symptoms a little bit. But now we're getting into an era of trying to fix the genes themselves, to go to the source of the problem and try to fix the source of the problem, which is the gene. So gene therapy is emerging as these new therapeutic approach and strategies aiming at modifying the disease rather than just treating the symptom, which is very exciting. But gene therapy for mitochondrial disease is fundamentally harder to do because of that heteroplasmy level and because of the fact that in each mitochondria, we have multiple copies of mitochondrial DNA, like you see here. So green is normal mitochondrial DNA, red is mitochondrial DNA that has the dysfunction or the mutation or the change in the letter code. And so what therapeutic strategies for mitochondrial DNA gene therapy do is we need to be able to remove enough of the red circles and keep enough of the green so they reproduce and make copies of themselves to end up with a cell that has healthy mitochondrial DNA and less of the diseased mitochondrial DNA. So in theory, it's feasible, but it's harder to achieve than to talk about it. There are many ways of doing this, and scientists have come up with many, many ways, including cutting into the DNA or changing the letters within the code by editing them. And there are many other approaches that try to augment, or what we call mitochondrial augmentation therapy, where we are adding healthy mitochondria into the cell by different means, including injecting them directly. But the takeaway is that these approaches are attempting to address the root genetic problem, which is great, right? Because we need to fix the problem. However, they are still in very early stages. They are not currently available treatment for individuals living with MELAS today, but there are people working on 3243 changes specifically. So hopefully the MELAS will come very soon. And then Some strategies try to prevent passing on the mutation to the next generation. So this is not trying to cure the disease, but trying to eliminate the disease from propagating throughout the next generation of people. So this is what mitochondrial donation does. It refers to assisted reproduction techniques in which a healthy donor mitochondria are introduced into an egg to prevent transmission of the pathogenic maternal mitochondrial DNA variant. So by replacing the mitochondrial DNA that has the mutation or diluting it with normal mitochondria at the earliest developmental stage of the embryo, mitochondrial donation might enable the birth of genetically related children with dramatically reduced risk of inheriting the mitochondrial disease. So this is a preventative measure again. And this is no longer theoretical because in the UK, they've been doing this for many years now. And in July 2025, they reported on the first 8 babies born from this technology. All of these babies were born from mothers who had a mitochondrial DNA problem, not the 3243 mutation, because that's a tricky one, right? It's very heterogeneous. So we haven't been able to do that yet for 3243, but other mitochondrial DNA mutation, which are more predictable, have now successfully been removed from these births, from these babies born to these women. And now the idea is to follow these babies over many years to see whether anything changes over time. And so this is very promising. And then likely in the future, it'll translate into MELAS. So to finish the new therapeutic era, I wanted to share some exciting news. I'm sure you've heard, but since September of last year, we've had 2 approvals for ultra-rare mitochondrial disease subtypes that demonstrated that the FDA and the regulators in Europe are willing to engage when they have robust data and when trials really align with what is most meaningful to patients. So we have the approval for Forcinity for Barth syndrome, and we have approval for Kygevvi for TK2 deficiency. And this is exciting because now the door is open and many more therapies might be approved. So to conclude, taken together, MELAS represents a severe heterogeneous mitochondrial disease with high patient burden, unpredictable progression, and major unmet need. But the field is changing. We now have better definition of what MELAS is. We have better outcome measures of fatigue and cognitive problems. We are more careful in how we design these trials, and we have new technology that will enable us to go to the root problem and fix it. And we have more global collaborations to achieve that goal of finding a cure, hopefully very soon. And so with that, I wanted to leave you with the UMDF MitoShare registry, because how you can help is that by registering in this MitoShare registry and sharing your symptoms and what is most meaningful to you. Registries are very important. They help us understand how many patients are diagnosed, what symptoms are most common, how the disease progresses over time, what the differences is between children and adults with the same disease. Without registries, it's going to be very difficult to be able to design good clinical trials. And when patients enroll in registries, they are contributing to research, even if they are not participating in a drug trial. And so this is my plea for you to enroll. And then on the clinical management side, we do have a mitochondrial care network, and we do have a website listed here that you can look up if you're trying to find a mitochondrial medicine expert close to where you live. We have about 21 sites, and we are increasing the number of our sites every year. And with that, I will stop here. And Margaret, I think we might have some questions.
I am back, yes. And I do have questions. I'm going to start with combining a couple of the questions that were in the chat. A lot of questions about heteroplasmy, age of onset, and severity of symptoms. Can you talk about that just a little bit more so that we can really understand it?
Sure. As I said, heteroplasmy is very tricky, right? So when we are doing genetic testing, the only heteroplasmy that we can check is the heteroplasmy within the tissue that we are testing. So if we're testing blood, that's the blood heteroplasmy that we're looking at. It doesn't really tell us what the brain heteroplasmy is or what the muscle heteroplasmy is. We can sometimes do buccal swab or urine test to look at the heteroplasmy. But again, that doesn't really tell us about everything else going on in the body. Urine heteroplasmy seems to be the best correlation to what's going on in the muscle, but we're not always able to do urine because we don't have enough clinical labs in the US who do urine testing for the whole mitochondrial DNA genome. And so technically, the higher the heteroplasmy, we assume the more severe the disease might be, and maybe the earlier the onset the disease might be. And that is true for specific mitochondrial DNA variant or mutation. But for the 3243, the most common variant that causes MELAS, that theory does not hold true. Because I can tell you, all of us seeing patients, we have patients with 3243 mutation that have 90% heteroplasmy. I have those patients. They have more than 90% heteroplasmy and they don't have any symptoms. And I have patients with 10 or 12% heteroplasmy and they have MELAS. And so for 3243, all the theory goes out of the window, and we cannot really correlate the heteroplasmy level with the age of onset, the severity, or what the prognosis would look like. We can do that for some other mitochondrial DNA, but not for the 3243.
Thank you so much for that very detailed answer. Then the next kind of group of questions that we received through the Q&A feature was about stroke-like episodes. Like, what are they? Can they look like a TIA? Can they look like aphasia? Are they the same as metabolic strokes? And what does it look like on the brain imaging?
Yeah. So stroke-like episodes can be interchangeably described as metabolic strokes. And what that means is that they don't follow the typical blood vessel territory within the brain. So someone who has high blood pressure or high cholesterol, when they get a stroke and we look at their brain images, we do see that the stroke is happening around a blood vessel that gets clogged or that gets ruptured, and that's where the stroke is happening. For MELAS, the reason why we call it stroke-like lesions, stroke-like episode, is because they can present similarly to a stroke with the same symptoms that I discussed. So you can have seizures, you can have weakness in any part of your body, you can have difficulty with your speech, you can have vision problems. So you can look like you're having any other stroke. But when we look at the brain MRI, the brain images, those strokes are happening in different areas of the brain. Usually it's in the back and the sides of the brain, and they don't follow the blood vessel territory. And so that's why they are called metabolic stroke, because what's causing them is not really a blood vessel that gets clogged, blocked, or ruptures, but because brain tissue itself is not having enough energy, so it starts exhibiting symptoms of cell death and swelling and all of that. And so stroke-like episodes can present in any neurological way, most often associated with vision changes because it happens in the area of the brain that controls the vision. And to be able to call it a really stroke-like episode, you have to have brain images that show that there is a lesion in the brain that does not typically follow a blood vessel territory. I hope I answered that question.
Very well. Thank you. Um, Quercetin, is that something you know about and can comment on?
No, I would. Can you say that again?
It's Quercetin. Someone
Oh,
in the chat had.
oh yeah. So I put that in the same bucket as a lot of other supplements and new compounds that are being trialed in many different diseases and being published in the lay press. There's a lot of stuff going out there. going on out there that claims to improve mitochondrial function and mitochondrial longevity and all of that. The problem is, in order for something to be safe and to work in our mitochondrial disease patient, they have to have gone through a very rigorous process of clinical trials that are well regulated. It's enticing to read about something and to want to try it because patients are desperate, and we do understand it's very frustrating to live with these symptoms and to try to do anything you can. But mitochondrial disease patients have a disabled body, a disabled metabolism that doesn't always handle drugs the same way as other people. And a lot of the stuff out there is really marketed for people who are getting older, who want to just to improve and boost their energy level. It's not intended for patients with a mitochondrial disease metabolism. So I would caution people to really discuss any of these things with their treating physician, to look at the scientific evidence and to look at their individual cases and to make an informed decision as to whether or not these supplements could be helpful in their specific situation or not. And also, a lot of the time, it depends on what the specific disease is and what the specific mutation is and what it is causing biochemically, because sometimes these supplements can be more detrimental if you take them in your specific disease than could be helpful.
Oh, thank you so much for that. I'm going to switch gears a little bit here. We at the UMDF has always liked to focus on the voice of the patient and realize how important it is. We recently had the externally led patient-focused drug development meeting with the FDA, focusing on MELAS. That was a week ago.
Mhm.
Can you comment on what you learned and kind of give an overall overview of that event?
Yeah, sure. And so that event was led by Mito Action. I have a slide to introduce Mito Action. And so, with in collaboration with UMDF and another advocacy group, this patient-focused drug development meeting was done. These meetings are structured as public meetings created by the U.S. Food and Drug Administration and designed to bring the patient's voice directly into the drug development and regulatory decision making. So these meetings really focus on understanding what is most meaningful to the patient living with the disease and what would be most meaningful for the patient to treat if the drug was to be found. And so the meeting was really well run. There were multiple families and caregivers and patients who presented. In the morning, we had the adult session where the adult patient and their caregivers talked about their day-to-day life and what their struggles are. And then in the afternoon, it was the children and the pediatric population. And then we had 4 clinicians who presented on the clinical and scientific aspect of what MELAS is, how do we diagnose it, and how do we manage it. I found the meeting to have been very successful in a sense that we really heard the concerns from the patient, both the adults and the pediatric, and we've heard about how intense the burden of the disease is, not just on the bodies of the patient, but also in everything related to their day-to-day life, their emotions, their social interactions, the financial burden within the families, how it doesn't just affect the one individual, but it affects multiple individuals within the same family. What I've learned and what was really strongly reported across age group is that fatigue again and cognitive decline are really the major aspect of MELAS that patient really want to act upon and to treat. And any improvement would be meaningful to these patients and if we improve their fatigue and their cognitive decline. I can tell you that there were about 220 attendees in the meeting. There were 6 adults and caregivers that spoke about their experience, 5 pediatric and caregivers and patient, and there were 34 attendees from the FDA, which is a large number. And so at the end of this, a patient report is going to be published by Mito Action and the other advocacy group. That patient report is going to include polling questions that were asked during the meeting for those attendees who attended virtually that were not part of the patient panel that discussed their symptoms. We've also done some survey questions before the meeting to better understand how living with MELAS is impactful to patient, and those results are also going to be published. The voice of the patient report will be shared through the Mito Action website, and comments are open until March 15th. You can find the report here on mitoaction.org, and the recording of the meeting itself will be available at the end of this week on the Mito Action website as well. And then Mito Action is going to start having MELAS support groups meeting monthly. And if you want to participate, you can email Sherry at this email address. So overall, I think it was a very successful PFDD meeting. It was well organized. We had good representation of adult and pediatric patient. We've heard loud and clear that this is a very burdensome disease, increasing the morbidity and also affecting the quality of life, not just for the patient, but for the whole family nucleus.
Thank you so much, Dr. Kara. I want to also alert the community that at Mitochondrial Medicine 2026 this summer, we will be having a dedicated MELAS gathering. So for any patient families that are considering coming to mitochondrial medicine this year, this is the year for the MELAS patients to join us, and we look forward to seeing you there. I also wanted to, and I'm thinking we may have to, I don't know if there's a slide that's going to pull up, Kara, that talks about our March 9th Ask the Mito Doc, which is going to be about clinical trial readiness and sort of information and results from our research pavilion from last year's mitochondrial medicine. It's always a really important session. I learned so much last year, and I'm really looking forward to it. So I hope the rest of you will join us as well. Everyone have a great day. Thank you so much, Dr. Kara. That was informative. Really, really. Oh, there's my slide. And we have some other Ask the Mito docs that are coming up too. So please mark your calendars and join us, and we'll see you all next month. Have a great day, everyone.